So welcome everyone to this new edition of the Fujita Bantane webinars. First of all, I want to welcome my co-chairs today, Professor Ishu Bishnoi and Dr. Ari Kiran. Thank you very much for being here and helping. And of course, Professor Iyoko Kato, our leader and mentor, and actually the mind behind this kind of webinars, I have to say. Today, we have two great speakers with really interesting talks, Professor Naoki Otani and Dr. Petra Wacho-Pramono. I would like to ask, before starting with the introduction of the first speaker, I would like to ask Professor Iyoko Kato to give a few words to introduce this webinar.
Okay, thank you very much. So everybody seems very fine and also seems very happy. Ishu, are you fine?
Yeah, Professor, I'm good.
What about the new baby?
Yeah.
Okay.
He's okay. He's good.
Okay.
I'm
Just I
happy.
returned from Okinawa because there was a meeting of the neuro dementia meeting. So I think Japan is very geriatric the period now. Many people are going to very senior stage. So I think dementia meeting was very nice. So maybe sometimes we can have such a topic. Maybe someone can talk. 大谷先生、誰かどうでしょうか、認知症のお話できる脳外科の先生って、先生、中根先生ですかね。ね、中根先生。先生、声は聞こえません。
ちょっと先生、探してみます、先生。
そうですね、お願いします。
はい。
Maybe very important issue, I think. Thank you very much. So I expect the very good the two lectures today. ありがとうございました。はい。
Thank
you. 先生。
Okay, thank you very much, Professor Kato, for this introductory talk. I would like to introduce our first speaker, Professor Naoki Otani. Professor Naoki Otani is currently a clinical professor at the Department of Neurosurgery at the Nihon University School of Medicine in Tokyo, Japan, and executive manager at the Center of the Brain Tumor and Skull-Based Lesions, vice president at Nihon University Hospital in Tokyo. He completed his training in Japan, but also abroad. He had a clinical fellowship at the Department of Neurosurgery in Zurich, Switzerland. And he has several interests, especially about trauma, skull-based tumors, cerebral aneurysms, bypass surgery, and microvascular decompression. We have the pleasure to have Professor Naoki Otani here today talking about surgical strategies and tips for smooth and safe resection of paracellular neoplastic lesions. So thank you, Professor Otani, and you can start sharing your screen.
Yes, thank you for introducing much for me too. Thank you, Professor. So I will share my slide. Okay, just a moment, please. Can you hear me?
Yes, we can see your screen.
Yeah, just a moment, please. Can you see my slide?
Yes, Professor, we can see.
Okay. Thank you so much. So Professor Iyoko Kato and Dr. Ferretti for invitation on this webinar and giving my opportunity for present my clinical works. So today I would like to talk about surgical strategies and surgical tips for paracellular lesions. So in particular, I will talk on the focusing on the extradural surgical procedures. So this slide shows the selective extradural anticlinoidectomy, so proposed by the Professor Yashajiro and Professor Yonekawa of the University of Zurich, which is a so-called classical method. This is a classical method. So during my stay in Zurich, they often said that if you can get these extradural techniques, you can perform paracellular lesions safely. However, in this method, so epidural space is so narrow and difficult to understand the anatomical component around the optical canal. So on this way, the Professor Day and in USA developed Dorenk approach. So as extradural temporal approach. So this approach provides us the wide epidural space enough to expose the anterior clinoid process entirely. Therefore, we can drill it away safely. You see? So on the other hand, this technique needs extensive peeling of the dura propria of the lateral capital sinus. So there is a risk of cranial nerve injury during the dural peeling. So in this approach, we can get early exposure and decompression of the optic nerve. So early so we can perform the early devascularization and detachment by the tumors under precise orientation. And finally, we can get the wide retrocarotid space and optical carotid space to approach the interpeduncular system safely. So in this approach, we have to cut the meningovital band and peel the dura propria. Then we have to know that these two important anatomical structures. So meningovital band is a periosteal fold between the periorbital and the temporal lobe. Secondly, the lateral wall of the capital sinus is composed of two layers, such as dura propria of the temporal lobe and inner reticular membrane that separates the neurovascular structure in the capital sinus of the lateral wall. So, and then anterior clinoid process is anchored with the three bony structures. So lesser wing of the sphenoidal bone, root of the optic canal, and the optic strut. So therefore, these structures have to be removed for complete anterior clinoidectomy. So I will show the surgical procedures of this approach in actual operation. So at first, superior temporal artery should be harvested and spared. Can you hear me?
Yes.
Yes.
Okay. Sorry. So unstable of the internet is unstable circulation. So interfascial dissection, zygotomy if needed. So orbital angle of the lateral orbital wall. So I will show the video.
大谷先生、
そう
なんかちょっと声が時々途絶えます。
あ、そうですか。
はい、
す
大
いません。
丈夫です。
はい。
ほぼ OK です。はい。
CS drainage will be needed in these cases. So I open the Sylvian fissure to drainage the CSF. And finally, superorbital fissure and foramen rotundum can be confirmed like this. Here is a superorbital fissure and the lateral, foramen rotundum. At first, you see you should fully expose the meningoorbital band and open the orbital apex. And then, even if the intraorbital fat protruded, we should only just cauterize with bipolar forceps to hemostasis and put its orbital fossa, not use bone wax to stop the bleeding, because the bone wax can get stuck in the orbital fossa, with which can cause diplopia. So on this time, anterior crinoid process was just removed from the lesser wing. Just here is just removed here. So next, superorbital fissure was skeletonized and roofing to confirm the interreticular layer for peeling the dura propria with the lateral capital sinus. So as you see on this time, so this area, so surrounding blue line was just removed on this time. So I will show the reason why do we need the unroofing of the superorbital fissure. So there are three coronal sections of the superorbital fissure and the foramen rotundum and the foramen ovale. So the most important thing is that the dura propria invaginated into the SOF like this. So on the other hand, there's no such invagination in the foramen rotundum and the foramen ovale. Therefore, unroofing of the superorbital fissure will be needed to expose the junction of two dura layers for peeling of the lateral capital sinus. So next, so we are peeling of the dura propria on the inner reticular layer. So any instrument can be used which depend on the operators. At that time, the sphenoparietal sinus should be spared on the dura propria side. Meningoorbital band was cut. After these peeling procedures, we can retract the temporal lobe over the temporal dura, and then we can easily dissect until the tip of the anterior crinoid process. So next, we can see the optical canal epidurally. Then you can expose the fully anterior crinoid process as green line like this. Next, unroofing of the optic canal is done like yellow line like this. So remnant of the anterior crinoid process, which consists just of the optic strut, finally removed. So hemostasis was easily done using surgical cottonoid with fibrin glue like this. So I will show the several clinical cases. This case is a tuberculum meningioma, not so large in diameter, but her left visual acuity was gradually worsening. Finally, just only the light perception. So I will show you the video. So after left side front temporal craniotomy, meningorbital band was fully exposed, and just only the orbital apex was opened, skeletonized, and roofing of the superorbital fissure. So you can see the inner reticular layers here. So meningorbital band was cut and peeling continued towards the inner reticular layers. So you see the optic canal epidurally. So optic canal was opened like here. Here is the optic canal. So optic channel was opened and roofing. You see the remnant anticlinal process was anchored just optic struts and remove it. So intradurally, so falciform ligament was cut to decompress the optic nerve and detach the tumor. So tumor is so soft. It's not so difficult to internally decompressed. And you can see the contralateral side of the optic nerve and dissects the communicating artery. And finally, you can try to remove the tumors like this. And this case is a huge sphenoidal rich meningioma. She suffered progressively worsening cognitive dysfunction. So I will show the video. So right side front temporal craniotomy, meningoorbital band fully exposed. Just only the orbital apex was opened. Skeletonized and roofing superficial, so inner reticular layer, and meningoorbital band was cut and peeling and continued towards inner reticular layers to dissect fully to expose the anterocranial process entirely. So, so here is inner reticular layers. So we can, after the peeling of the dura propria, we can retract the temporal lobe about 2 centimeters from the base of the temporal lobe. So you see the optic canal epidurally like this. So optic canal was opened and unroofing safely. So no drill technique. We preferred not only just using the micro punch. So after you see the optic canal, so after dural opening under precise orientation of the optic canal, detachment was easily continued. And then in the early stage, during the surgery, you can confirm the optic nerve and internal carotid artery. So you can easily continue the internal decompression and detachment from the surrounding anatomical components. So final view of these cases. So next case was very rare cases. So this young female suffered oculomotor nerve palsy. We have firstly diagnosed that this tumor might be oculomotor nerve neurinoma. We have decided to perform the gamma knife therapy. So the patient was very uneventful, but after that 6 months later, after gamma knife therapy, she suffered uncontrollable retroorbital pain. Then we have performed tumor resection. So in the same way, we have performed extradural procedures. So optic canal is opening, and so final anterocranial process was completely removed. So you see it. So intradurally, the tent was shaved, and you see the oculomotor foramen was opened, and the tumor came into view. The tumor adhered with the oculomotor nerve. So we removed the tumor piecemeal fashion like this. Finally, the oculomotor nerve palsy was completely suffered. But about 10 years later now, the no recurrence, and the patient is good, healthy, uneventful. And the last case suffered abducens and dysphagia and oculomotor palsy, and the tumor mainly existed in the cavernous sinus. Sorry. So video, I will show you the video. So after extradural procedures, you see the Malan triangle between the V1 and V2 and V3, V2 and V3. So the tumor is so soft, and between each nerve, we can easily remove the tumor like this. So finally, we remove the remnant. Sorry. Okay. Finally, we remove the remnant tumor protruded the Doreros canal. This is a final operative view. The post-operative image shows the subtotal removal of the tumors, and the post-operative course was uneventful, and eye movement showed full recovery. So, but this case shows pathological findings, the controlled sarcoma. So we have performed additional gamma knife therapy for remnant tumors. So as shown in this slide, there are some surgical pitfalls in these approaches. So CSL leakage, venous infarction caused by sphenoparietal sinus injury, heat, and mechanical injury of the cranial nerves, venous bleeding from the cavernous sinus and the meningovital artery and the central retinal artery, and we have to check the pneumatization of the anterior cranial process. So in each pitfall, I will explain. So to avoid the CSL leakage, we usually use spinal drainage, and 100 to 150 millimeter per day drainage of the CSF, about 3 days. And to avoid the opening the ethmoid sinus preoperatively, we have to check the pneumatization of the anterior crinoid process, like here. So in these cases, we have to avoid the extradural crinoidectomy, so surgical procedures. We should avoid in these cases. So next, so venous infection caused by the sphenoparietal sinus injury. So we have to avoid these sphenoparietal sinus injury. So sphenoparietal sinus should be spared on the dura propria side during peeling of the lateral cavernous sinus. And to avoid the heat and or mechanical cranial nerve injury, we prefer to use these micro punch for optic canal opening and extradural anterior crinoidectomy. So previously we use drill out the anterior crinoidectomy, but about 23 or 25% of the patient shows partial visual field, so visual field deficit after post-operatively. So that we changed the crinoidectomy for the no drill technique for just using like micro punch. So after that, we did not experience in these deficit after surgery. And for bleeding control from the cavernous sinus, surgical cottonoid and fibrin glue is just useful And using these material, we can stop the venous bleeding easily from the lateral cavernous sinus. But in addition, as shown in this slide, we sometimes use direct injection of the filling glue in each 1 millimeter from the bleeding point. It can be easy to control the venous bleeding from the cavernous sinus. And we have to check the blood supply of the retinal artery. So in this case, the left cavernous sinus meningioma. So the ophthalmic artery is completely occluded. The only source of blood supply to the retinal artery is just the middle meningeal artery. So then we cannot cut the meningoorbital band. And then we just finished the optic canal opening and tumor resection just only around the optic canal for preparing for the gamma knife therapy. So after that, we have removed the transsphenoidal approaches and gamma knife therapy, perform the gamma knife therapy for remnant tumors. And so now the visual acuity is gradually improved. And the last pitfall, so we have to check the size and shape and pneumatization of the anterior cranial process and the relationship with the sphenoid bone and the ethmoid sinus and the anterior cranial process. You see the cortico-crinoid foramen like this, and intercranial osseous bridge like this. So extradural anterocrinoidectomy can be, in these cases, contraindications. So we have to assess preoperatively like this. In these cases, we avoid the extradural crinoidectomy, and we have to select the intradural crinoidectomy if needed. So now we are coming to the end of the presentation. I hope you have gained some knowledge about these topics through my presentation. Thank you for your attention.
Thank you very much, Professor Otani, for this wonderful presentation. Very clear, despite very difficult cases. I would like now to open the discussion. So I ask I see also Petra Uwakopramono joined us. Hello, Petra. Good to see you. I would like to ask the audience about questions, if there are any. Maybe I can, well, I see actually some raised hands. So Ben.
Yes, thank you so much, Tani, and a very educational lecture about dealing with the paracrinoid meningioma and also the anterior crinoidectomy, and it's a very beautiful dissection. So I really echo with your idea that way to check the pneumatization of the ACP is very important, especially if you consider there may be chance of CSF leak if you do open the pneumatized ACP, that you need to consider doing some repair of it. My question is about how about in the case of the carotid crinoid ring? Sometimes there may be a ring-like structure connecting the anterior crinoid with the middle crinoid process. So do you have any experience in during the ACP in that cases? And what kind of the precaution that we might need to consider?
Thank you. 𝒂𝒂𝒊 𝒂𝒂💄
Yeah. Sometimes it's a bony
yes,
structure.
yes. So I have several cases. I have several cases experiences. So in that cases, of course, extradural clinodectomy is partial. We can perform the partial clinoidectomy. So in that cases, but if we have to complete clinoidectomy is needed, so we have to change the intradural clinoidectomy. Intraoperatively, we have to change the. You understand? But intraoperatively, when you shoot clinoidectomy, I do not recommend the drilling. You use the drilling. It's only just you understand that not.
Yes. Yes, understand. You mean that if we need to do it, then we do the partial anterior clinoidectomy in extradural manner, and then we switch to intradural, right?
Yeah.
I see.
Intradural clinoidectomy. When you shoot intradural clinoidectomy, you do not have to use the drill. So we prefer to sonopet, you know.
Yes.
Sonopet is better. If you intradurally clinoidectomy when you
I see. Thank you for your advice.
Thank you, Petra. Petra, we cannot hear you. For some reasons, we cannot hear you.
Is it okay?
Yeah.
Oh, okay.
Now,
is it okay?
Yes, now we can. Yes.
Thank you. So, Otani Sensei, thank you for the presentation. I want to follow up on the question. How do you like to use a sonopet for extradural drilling too? Hello?
Yeah. No. When you shoot intradural anterior clinoidectomy, I recommend you should use sonopet, not drilling, not using the drill out.
Oh, okay, thank you. Because the company is offering to me saying it's also good for extradural drilling because it does not damage the dura layer.
Yeah.
Okay, thank you.
In extradurally, when you perform the extradural clinoidectomy, previously I will use the drilling, but now I usually use only the micro punch extradural clinoidectomy for extradural clinoidectomy.
Okay.
Thank you.
Okay, I see Dilshod has a question.
Hello, everybody. Do you hear me?
Yes, Dilshod. Hi.
Thank you for organizing. Thank you, Sensei, for a nice presentation. I have a question. When you have resected the tumor of the oculomotor nerve, you said that it was neuroma of the oculomotor nerve, right?
Yeah.
Okay.
Oculomotor meningioma. Yeah.
In case when you transect the nerve, oculomotor nerve, with the tumor, obviously there is a gap between the peripheral nerve and the coming central nerve. I mean, the nerve has been resected. Did you have any experience, or do you have any idea of grafting these resected nerve bundle? I mean, do you have any idea of neurotization of the oculomotor nerve? Any practice, any article, any idea?
So, your question is a reconstruction of the oculomotor nerve,
exactly.
or reconstruction. Thank you for your good question. So, I would like to reconstruct the oculomotor nerve, but it's we can prepare some sural nerve. We can prepare the sural nerve and so artificial nerve sheath now, but it's not suitable for the oculomotor nerve. So we cannot reconstruct the oculomotor nerve now. Then we cannot reconstruct the oculomotor nerve. So yes, but several reports have several papers have reported that the oculomotor nerve about the reconstruction, oculomotor nerve reconstruction. But I could not reconstruction in my technique. Yeah.
So this short, maybe you encounter such case?
Because it's
this short?
we have seen, yes, we have seen many cases with meningioma, but in case this particular case was rare for us, so haven't seen any reconstruction so far. That was my interest. Maybe Sensei has some other experience.
Sensei, maybe I think in such case, radio surgery is a good indication. How do you think?
Yeah, of course. Thank you for your question. So, of course, at first we selected the gamma knife therapy, but 6 months later, the gamma knife therapy. So she suffers uncontrollable retroorbital pain. So that we have to resect the tumor for the decompression and the pathological findings, definitive pathological findings. So at first, I will misdiagnose for the oculomotor nerve neurinoma. So, but
understand.
Thank you so much.
Others?
Yes, I also have a question, Professor Otani. So you showed some cases where you performed surgery in the cavernous sinus and gamma knife on the remnant. So my question is, do you have some fixed limits for surgery during this kind of operations? So when you reach those limits, you say, okay, going over those limits is too risky, I will stop and send the patient to gamma knife surgery? Or it really depends on case by case? If the tumor is too much attached to some important structures, you leave it behind. I mean, is there any rule to understand when to stop doing surgery in the cavernous sinus, or it's something you decide case by case?
Thank you. So it's I think it depends on the pathological findings. So in that cases, so chondrosarcoma chondrosarcoma, we have to remove as much as possible, But as you see, the adhered is so severe with the internal carotid artery. We have to stop the operation, of course. But in that cases, presentation in this presentation, so it's so soft and adhered with surrounding nerves and internal carotid artery. So so safely, it's of course. So it's the most important thing is that the tumor, so surgical purpose, mainly purpose is so definitive pathological findings and so decompression. So it's my philosophy for the cavernous sinus tumors resection. So you understand my opinion?
Yeah. I got it. Thank you very much. Is there any other question from the floor for Professor Ohtani? So if not, I want to thank Professor Ohtani for this great talk and also for the very active
Excuse me.
maybe. Dr. Dutta?
Yes, can I ask a question if I have the permission?
Yes, of course.
Thank you, Professor Sensei, for such a wonderful talk. What I wanted to know is when you operate on these kind of meningiomas, there is every chance that you might, in case the tumor is adherent to the ICA, you might end up in injury. So my question is, do you use 𝒂𝒂𝒏 for these kind of lesions? And also, do you use micro-Doppler to somehow localize the ICA?
Thank you. Thank you so much. So yes, so the most important thing is that the relationship with the tumor, between the tumor and the internal carotid artery and the M1 and yes, of course. So the tumor is adhered is so severe. We usually intensively partial removal, and for the gamma knife therapy. And I usually prepare the bypass surgery, of course.
Okay.
Yes. For so in just happened. Yes, just happened. Internal carotid artery injury or the dissect of the internal carotid artery. But I have never experienced for the injury of the ICA or the M1. You understand?
Okay, Professor.
Yeah.
Do you use Doppler? Do you use micro-Doppler?
Yes, I prepared usually. Yes, I will check the Doppler, micro-Doppler, of course.
Yes. Okay. Thank you so much for your answer, Professor.
Thank you. I see also Dr. Sharif raised his hand. Please, Dr. Sharif.
Thank you, Professor Ohtani, for your excellent presentation on skull-based meningioma. I have interest on this area. Endoscopic endonasal I prefer most. But you presented a case that is the second case. It was a large lateral sphenoid wing meningioma. So is it invade the overlying bones? Do you remove that bones? Otherwise, there may be a chance of recurrence whenever it invade the bone. So if you remove the bone, then this part of the skull is very difficult to shape by cranioplasty. So what's your strategy?
Thank you. Thank you. So you question is so embedded bone. So when you remove the bone, so how do you reconstruct the skull?
Yes.
Bone. So the problem is the base, temporal base and frontal base is so removed is so problem. So because so to avoid convexity is not so
difficult.
Not so difficult.
Not so difficult.
But, but I usually use sometimes so inner bone inner table to cut and shave the inner table and to so to put the base of the temporal or the metal so artificial bone
titanium mesh sometimes can be used.
Yes. So should be prepared for these so this condition, pathological condition.
Thank you, Professor.
Thank you. I see also Dr. Felici raised his hand.
Say for your presentation. Just a question. So I am Yassine, Dr. Felici from Algeria. I am fellow in Bantan Hospital under supervision of Professor Kato. So my question about the third nerve palsy. In after craniolectomy, did you have in your experience this kind of complication, or after injection in the cavernous sinus fibrin glue, third palsy, in the third nerve palsy, after injection?
Thank you. So I have ever experienced about 10 or 15 cases, just only 15 cases, but I have never experienced the complication for the direct injection of the cavernous sinus. But so several reports have checked that sphenoparietal sinus venous congestion is so we might be afraid to venous congestion of the supraorbital fissure or the sphenoparietal sinus. So we have just afraid to. So in that cases, so cavernous sinus drainage is only just not sphenoparietal sinus. So we have to. So you understand? You have to
yes.
care. You have to care. In that cases.
About for the third nerve palsy, I say. The third nerve palsy.
Third nerve palsy.
Third nerve. Oculomotor nerve.
Oculomotor nerve. No, I have not experiences.
Okay.
Okay, thank you very much.
Thank you,
Ari, you have a question?
Yes. Thank you, Professor, for your excellent presentation. I have one question. Actually, I have two questions. One is because we cannot evaluate in every case the anterior clinoid process. So in the case we are doing extradural procedure, if we encounter the all pneumatization of anterior clinoid process, so how do we further proceed? So we apply bone wax, or for the prevention of CSF leak intraoperatively?
So CSF leakage, right?
Yes, yes. So when we are operating, if we encounter the pneumatization of ACP, then how do we proceed?
So one more, please. One more, please.
If we are operating and we are drilling the anterior clinoid process, and if we encounter the pneumatization, so then how do we further proceed? We put the bone wax on ACP, or how do we proceed?
眼気の多い APC を取ったときに、その後どうしたらいいですかって聞いてると思います。
いや、どうも、はい、どうもありがとうございます。So, for the pneumatization of the anterior clinoidectomy, so I understand. Yeah. So the pneumatization. So we have to check the pneumatization of the anterior clinoid process preoperatively, of course. So I usually avoid for the extradural anterior clinoidectomy for the pneumatized anterior clinoid process. So in that cases, we usually change for the surgical strategies for the intradural anterior clinoidectomy. So and in addition, when you perform the extradural anterior clinoidectomy, just happens opens the ethmoidal sinus or the ethmoidal sinus. So I usually use temporal fascia and temporal muscle, and and with fibrin glue, and to completely covers opened ethmoidal sinus.
Okay.
You understand?
Yes.
So because the CS leakage will be, so I'm afraid. So in that cases, and as I explained in my presentation, I usually continues spinal drainage about 3 days, and 100 and 150 millimeter per day continued.
Yes.
Okay.
Thank you. Yes.
Yeah.
Yes,
Hi.
Okay, if there are no other questions, I want to thank again Professor Otani for this presentation and also the very active discussion. Thank you also to all the discussants of this session. And I would like to hand over to Professor Ishu Bishnoi for the presentation of the next speaker, who actually texted me. He had to disconnect and reconnect, so I kindly asked Ben to promote Petra as a active member in the webinar. He had some video issues that I hope he was able to fix. I will also have to briefly disconnect because I have to drive now, and I will reconnect with my phone, but I want to ask Ishu Bishnoi and Hari Kiran to keep going with the webinar and introduce our next speaker. Ishu?
Thank you, dear Alberto. So, Dr. Hari Kiran, I think now you are ready to introduce our speaker. So, can you please introduce the next speaker?
Yes, Professor. Thank you. Thank you, Professor Otani, for your excellent talk. And I really enjoyed your talk. And our next speaker is Dr. Petra from Indonesia. He is a young neurosurgeon and is currently working as an assistant professor of neurosurgery from the University of Padjadjaran in Bandung, Indonesia. He is a recipient of several awards and honors, and is especially interested in minimally invasive surgery and clinical research. So now the floor is yours, Dr. Petra.
Hi, thank you very much. Can you hear my voice?
Yes, we can hear.
Oh, thank you very much. Okay, so let me share with you my screen. So Alberto came to me and asked me to present something about research in neurosurgery. Now, I'm sure I'm not as much a researcher as other participants here, but I would like to share with you my experience in research, because for my case, I think I'm very lucky that I have a setting that offers both clinical work and research work at the Universitas Pelita Harapan, where I work now. And so I would like to tell you how it's very interesting to integrate research into my daily neurosurgery, and it comes naturally for us. So for me, I think it's very important to underline that as a neurosurgeon, every day we are doing research just by waking up, doing our work, listening to workshops and reading our journals. We are thinking, and thinking is, of course, research. And research is, for me, communication and curiosity, how to serve my patients better, how to give better outcomes. And most of all, for me, research is love, because when we are passionate about our subject, neurosurgery, we always will try our best to make it better, and everything else will come after. So we package our curiosity into how to collect the data, how to document it, how to analyze it with the appropriate methodology. But all of that will come perfectly naturally for a neurosurgeon, I think. For me right now, my position, I'm an assistant professor in the Universitas Pelita Harapan, and I'm also an attending neurosurgeon in the Siloam hospitals. And for me, usually we do about 500, 600 cases a year. And from that collection of cases, we look at the patient and we try to analyze what problems that we can make better with the cases. We also have a nanotechnology center near our building, and we try to engage them in doing some animal lab work and some microbiological work. And for now, I think we are not all the way down to the molecules yet, but we are going down to the cells and tissues and trying to figure out how things work. And I think it's very important also in our daily life to improve our critical thinking and problem solving by trying to integrate our research to answer our questions, and also for advancing our career. It's something that we need to think about in our center. Now, I've been involved in several researches from early on. So mostly it's things I have to do. So I have to become research assistants to a couple of my professors when I was doing the neurosurgery program. But now I think I'm proud to say that I have moved on to doing things I want to do to get my own avenues of research. And I think in a little while, I will advance to doing things I have to know. So, for example, if I want to improve the outcomes of my patients, what I will need to learn. For example, a lot of the works previously is not focused, doing some case presentations, case reports. But now I've already gone on and done 1 or 2 meta-analysis, and we are doing some biochemical work on CSF physiology. So as neurosurgeons, we're always standing on the shoulder of giants, and we have to think about what research has been done for us previously. And for example, I see in the beginning of my career 5 years ago, a lot of the stroke patients are having high mortality and morbidity. And I think this is behind the curve for the global neurosurgery data. Although we have done all the clinical guidelines and predictive models that we have learned. So what's the problem? And it looks like the ones with intraventricular hemorrhage and hydrocephalus have the worst survival rates. And so we are right now in our center focusing mainly on intraventricular hemorrhage as the main thing that is causing morbidity. And I think we should do something about this. And right now, that is what we are researching in our center. So many nights I'm thinking, why should we do all this work? For example, we're neurosurgeons. We have dedicated a lot of our time for clinical works, and just getting research on top of that, I think it's a bit challenging. But I personally hope that with the results of my research, I can contribute for the management of stroke. I want to deliver better outcomes. I want to do better scientifically proven things. Lately they've been doing digital subtraction and geography here and calling it brainwash. It's not very scientific. I want to do better things for my patient and write my own clinical guideline. And I think that's why we do research. And a lesson I learned in a hard way from researching while doing a clinical work is that time management skill is very important. And usually because they ask me to do a lot of things and I say yes to a lot of things. Please join this research group. Please join that research group. Please collate all the data for research papers. And I say yes to it all the time. And I think it's very important we say no sometimes, so we can dedicate our efforts to the things that we really, really, really are interested in. And now I have started taking time. For example, all my Thursdays are dedicated for research. So I'll just do one case in the morning, and then the rest of the day, I won't take any appointments and all. I'll dedicate Thursday for research. And I think we started hiring 2 assistants, and it's very good just to get all the clinical data done, so we can focus on the data analysis. So I think as a neurosurgeon, time management is the best. Clinical research comes naturally because whatever you are doing, you're doing something good, and you are expanding, you are getting experience in things, and that will become the idea that you want to research. And when we are true to our ideas, we will find a way to make it work. So thank you for your time. My father gave me this picture once, boys be ambitious, because we want to be ambitious, we want to do research, we want to do the clinical work to be the best that we want to be. And I think that's a very good quote for a neurosurgeon. And I think that will be what I will be doing, what I will be basing myself on in the future. Thank you very much.
Thank you, Dr. Petra, for the wonderful talk. So the panel is now open for the discussion, and you can ask questions or you can give our comments.
So Petra, thank you very much. So just overlapping.
Sensei.
Hi, Sensei. Petra Sensei, こんばんは。
はい、こんばんは、先生。
元気ですか？
はいはい、元気です。
Yes, ありがとうございます。So just overlapping during your talk, maybe the overlapping your father. I think your father, Dr. Eka, is always one of the best friends, and also that he always emphasizing about you showed us the last slides. Your father is just very brave, the neurosurgeon, because he studied from the zero to such a highest position, and also that he can educate so many YNS from Indonesia. I admire your father. Thank you very much. It was a great talk. Thank you very much. Congratulations.
Dr. Harikesh, do you have any questions?
Hi, Dr. Petra. Very encouraging and a very nice presentation. So I wanted to ask you, what search platforms do you use, like PubMed, and what else do you use? I just wanted to know for my information.
Oh, thank you. So actually, I've gotten a lot of questions in this, especially during my meta-analysis days. So apparently, we can just keep it simple and use Google Scholar, because all the other platforms are integrated into it, PubMed and everything. You can actually use Google Scholar. And then you can try to find the ones that the universities give you access to. It's quite updated. And I think that's a very good place to start to identify the relevant articles. I usually identify only about 60 or 70% of articles from there, and then I do the rest by searching the references of those articles. Thank you, Dr. Hari.
Thank you.
Hari, there is suggestion that, like Dr. Petra said, you can go on the ResearchGate, and if the author is on ResearchGate, you can directly message him and ask for the article. And third is there are groups on the Facebook and the WhatsApp, the neurosurgery cocktail. There you can ask for the article or material for the research. And there if somebody has that article, he can provide or she can provide you.
Yes, Professor. Sometimes I don't get the article. That's what I was asking.
Yeah, articles, they are very expensive if you ask from the directly from the site. That's why these are the alternative ways. Like I get requests on ResearchGate for my articles. That's how I got to know that you can directly ask from the author, because author always has a free copy for him. He can share it. It's not against the copyright.
Oh yeah, thank you. Like Dr. Petra mentioned, one day for research, this thing I learned in my time during Japan. So for only Saturdays, we used to put the Saturdays for research, only for research. So that's how I have also incorporated some research into me now.
That's very good.
Yes, I think that's one of the side effects of the pandemic. We can focus on some academic stuff as well.
Yes, that you're right. And that's how you can continue with the research, because research is a time-taking process, and also writing paper and collecting data uh, other than the neurosurgery procedures, it's quite cumbersome, because now we all are family men. So beside doing surgeries, doing research, it's time-taking. But if you continue to doing small part, 1 hour a day, 1 hour a day, that's how you can proceed further.
Yes.
Hi, Alberto. Welcome back.
Yes, thank you. I was able to reconnect. Yes, I also think about this. Of course, we, as you mentioned, we don't have enough time to do surgery, to do research, to do study, because we need to study. And I just want to mention this idea that I heard at the last EANS Congress by Professor Rabe, who proposed to set up a team. Of course, this will be done. It is already done in the EANS, but it can be extended, I think, also in the ACNS. He proposed basically to have volunteers who can be updated only in a very, very, very small subfield of neurosurgery. So not vascular neurosurgery altogether, but maybe unruptured aneurysms or ruptured aneurysms, or something very, very specific, and check every once in a while all the papers coming out, because it's not possible to read all the papers that are published every month. So basically, if we are able to build up this team of experts of subfields, these experts will read only the papers about their subfield, and they will rate the papers. So if any other neurosurgeon wants to do research or study about that subfield, part of the job is already done by the experts who already read the papers and rated them, basically. I think it's a good idea by Professor Rabe.
Yes, you're right. That's a wonderful idea. So, yeah, Dr. Ben, please.
Yeah, I just wanted to echo with Professor Alberto about this idea, because I also saw some I also joined some social media channel, for example, like WhatsApp or Instagram or Telegram, about those groups. Sometimes it's useful that they develop some subspecialty interest group. So they occasionally share some material concerning the different subspecialties. Some of them are quite useful and provide some up-to-date information about, or some leading edge research about the future trend. Some of them is quite useful, and I agree that the idea of FHU that for example, some subspecialty may have a or you can call it like ACNS journal group or journal club, or of different subspecialty that which is led by some giant or some expert in the field, then it will make the things even better. And also, I like Petra's. I'd like to see again, Petra, and I also like your lecture and your idea that the time management is very important, especially for we do long hour surgery and we don't have enough time for research and time and also our own life. And thank you so much, Petra, for joining.
Thanks, Ben. Thanks so much.
Thank you, Dr. Ben. So I would ask Dr. Perjad to comment and give your advice. Professor Perjad.
Hello, konnichiwa, salam alaikum. Thank you, Dr. Petra. It's a nice presentation, and it's famous talk about medicine is an ever-changing science, and we need to do research and do upgrade our works and experience by doing research as well. And it's very important, and thank you very much to share nice topic with us. Thank you. Arigato.
Thank you, Professor Perjad. So do you have any suggestions, Dr. Otani?
Thank you for good presentation for Dr. Petra. So I one question. I also impressed your motivation for the clinical and basic research. And one question is how to do you have to proceed with research theme? How to proceed with your research theme? So basic or the clinical or the translational research. So are you? So you understand? Okay.
Yes, Sensei. Actually, what we did is because our university have a lot of young people, and right now what we are doing, we are actually building for different groups. We have three different research assistants. For example, one person will specialize in the research and meta-analysis, and another specializing in basic science and animal models, and the third person will specialize in clinical research. Now, specializing not meaning that they do it, but that they understand the protocols, what to prepare. So when we have an idea, and they'll know, okay, I'll just use this form, fill out this, and then I will take care of the ethical review board schedules and everything. So it's a lot of work for one person. So 5 of us, 5 of our young people, we are paying this assistant, these 3 people, out of our own pocket, not using the university money, and they will get their names also published. So in that way, everybody wins. We can get our projects done, they get the experience, and later when they go to do their specialization, they will bring some new people inside. So I think that's a good beginning for a research team. So we just delegate the task, what we don't have time to do, and then they will become experts. In half a year, they have become experts. I think.
Yeah. Thank you.
Yeah, actually, if I can, I also want to congratulate Petra, because for everyone, especially for us neurosurgeons, time is a major issue, but sometimes it's also an excuse, right? So I see some of my residents who are very good in clinical stuff, but they say they have no time to be involved in research or in studying. But of course, it's an issue, but it's also an excuse we take to avoid, being committed to something else, which is not just a clinical or surgical job. So research is also important, very important. So I want to congratulate with Petra and his team, because you are actually finding the way to overcome this problem. So very, very nice job. Very nice job.
Thank you, Alberto.
So the background, the conversation, but sometimes in Japan, maybe 1 or 2 years for PhD study. So totally devote only for this research work. But I think once you come back to the clinical work, so just you do the every Thursday, the research day. I think it's very, very important. I think you should, when you during the younger age, you should continue your research, even hectic the clinical work. I think.
Thank you, Sensei.
Thank you for the talk, Dr. Petra. And if there are any questions or comments?
Yes, just a question. I would like thank Professor Petra for this presentation. My question is which advice you can give us to continue in the research work?
So I think it's a very good question, because I'm from Indonesia, and we don't have many advanced medical facilities or advanced research facilities. So I think we should focus mainly on what is the problem that is bothering us so much. I mean, for me, it's the intracranial hemorrhage patients, because there's a lot of them, and the outcome is not so good, and that is what actually leads me to doing research specifically on the hydrocephalus and the cerebrospinal fluid physiology. And then because I was following that topic, I know some people who are working in the labs, and they are actually using the same reagents that I want to use. So really, if we are curious, and if we just have a lot of conversation with a lot of people, not only neurosurgeons, usually outside our field as well. For example, I was talking to the biochemist, and I was talking with the statistical research group when they introduced me to these people. And if we do not have the resources for ourselves, we should really just spread our web as far as possible, and we see what happens then. So I think that might also be applicable for us young neurosurgeons. Thank you.
Thank you.
So Professor 𝑒𝑑𝑒𝑢, kindly give closing remarks.
Yes, we had a very good the 2 talks, especially Otani Sensei. He would have a neurosurgical acute medicine congress in next the February. I think some of you will visit the Japan, Tokyo. They are waiting here coming. And Otani Sensei is one of the best skull-based neurosurgeon. Even the endoscope or some other technology has developed. But I think such kind of the open surgery is still very, very important. Sometimes we need, especially for young doctors, you should learn the very basic techniques, I think. And Petra, I know him since he was very young, I think, that he developed very rapidly, and now that he is a great neurosurgeon now. I think in the future, Indonesia is a very promising country, I think. So, Petra, I think that you can be the leader of the Indonesian Neurosurgical Society, and that you can encourage the more YNS in the future. That your talk was very educative and very encouraging for all of us. Thank you very much. And with that, thank you very much for your the patient and listening for the two lectures. I think you can invite the Afghanistan YNS for webinar. Thank you very much.
Okay. Thank you. ありがとうございます。
ありがとうございました。
Thank you. Bye bye.
Bye. Next time.
Bye. ありがとう。
Bye. また来週。
Bye bye everyone. Thank you.
また来週。
先生どうもありがとうございました。はい。
はい、おやすみなさい。大谷先生ありがとうございました。
どうもありがとうございました。